So let's start with some introductions. Paul, why don't you go first?
Dr. Paul Thomas, family physician, CEO of Plum Health Direct Primary Care. We work with individuals, families, employer groups, municipalities, school districts to lower the price of healthcare through excellent, accessible primary care.
Nice. Thank you. Shannon.
Hi, I'm Shannon Biergans. I'm a board-certified family nurse practitioner and patient advocate. And I started Advocate, which is a patient advocacy service, because I saw both on the provider side and on the patient side that relationship was broken and patients were losing their voice in determining the choices they were making for their healthcare. So employer groups add me on as an employee benefit to help their employees have a voice in their healthcare choices.
I'm Dean Jargo, CEO at Fair Market Health. Fair Market Health is an online marketplace that makes prices transparent. It basically delivers a lot of the things that Shane was talking about. So when plan members visit our site, typically as an offered employee benefit, typically with zero out-of-pocket costs, the members can shop for the services they need, see the full all-inclusive price for that service, and put it in their shopping cart and buy it at fair and transparent prices.
Thanks. Appreciate the intros, guys. What I'd like us to start with is, again, don't be tempted to think, oh, maybe this can work for my company. We hope that it does. Maybe there's a fit there. But I think more importantly is let's pay attention to the problems that these guys are solving, the obvious problems. Paul, we'll start with you. Why don't you tell us the problems that you solve or the problems that direct primary care solves in general?
Yeah, so I'll start with the definition. Direct primary care is a relationship directly between your doctor and you, the patient, or the doctor and the employees. And we use a monthly membership model, so a cost per person per month to deliver that care. And we reduce our panel size from 2,500. If you hand one of your employees an insurance card, they are now one of 2,500 people that see one doctor, which is a lot, right? It's too many patients, and those patients get 10 minutes with their doctor after waiting an hour. We reduce that panel size to 500, and so we can now spend an hour with each patient, work on care navigation, be comprehensive in our care, and we can be accessible. So if we spent an hour with every patient that we saw each day, which is about 5 to 7 patients each day, we'd still have 3 hours to 1 hour to handle the phone calls, text messages, emails directly from our patients, as well as the urgent care needs of our patients in office, same day, next day. So with the direct primary care relationship, we guarantee a same day or next day appointment. The contrast is if you called your doctor's office right now, how long would you wait to see your primary care doctor? Shout out the number of days, hours, minutes, weeks.
A month.
1 month. Anybody, any other takers? Any other takers?
Give or take.
6 months.
6.
Yeah, so the average in Michigan is 28 days. 28 days for your employee to pick up the phone and say, I want to see my doctor, to the time they get in for an appointment. And we wonder why healthcare prices are rising is because your employees don't have a relationship with the most important person in the healthcare system, their primary care doctor. And so instead of seeing their primary care doctor for a $100 or $200 or $300 visit at most, they're now going to the urgent care at $350 a visit, or the emergency department at $2,000 a visit. They're directing their own care because they don't have a good quarterback, and you're paying for it as the employer. So with a direct primary care doctor, we reduce urgent care visits by 75%, and we reduce ER visits by 40%. And then we also decrease specialist referrals. A lot of your employees are going to see a dermatologist for a mole removal, which could be done in the primary care office at 10% of the cost that the dermatologist would charge. Similarly, a knee injection might cost $10 at a DPC office or direct primary care office. The orthopedist in their network will charge $1,000 because they can. So when you have great primary care that has a broad scope, that has immediate access, your employees get better care, you have fewer hospitalizations, fewer urgent care and ER visits, and you save money, all while getting like a concierge level of care from your doctor. Those are the challenges we're solving.
And
That's
you don't take insurance.
we don't bill or use insurance at all.
And you're not a replacement for an insurance either. I know there's questions on that. So hey, do I still need my coverage?
Yeah, most groups that we work with are self-funded or level funded, and they employ our direct primary care service as a way of lowering their downstream costs.
Yeah, great. So in summary, what I'm hearing you say there is you're trying to just change the way that when somebody needs care or help, they're thinking, I can reach out to Plum Health. I don't have to go, oh, I'm not going to get into my doctor, so I'm going to go to the urgent care or ER. They just know that you're raising the access and trying to get it more in a, like, I can reach somebody and I'm going to get something, it's going to get some forward movement.
Yep.
Right.
That same day, next day access is imperative. And then we're right sizing your primary care investment, and you get a downstream cost saving return on that primary care investment.
Perfect. Thank you. Shannon, what problems are you solving? And help us define the difference between the buzzwords of navigation versus advocacy.
Yeah, and I think that's a good distinction because care navigation and patient advocacy are often used interchangeably, but there really are some distinct differences between the two. So a care navigator is usually employed by an insurance company, a provider office, or a hospitalist, and they really help a patient move through the process of the healthcare system. They may assure that prior authorizations are completed correctly, that a test is approved by your insurance, and that you get scheduled for that test. Patient advocacy, on the other hand, is solely working for the patient. And our goal and our mission is really to make sure that you as the patient understand your diagnosis, your test results, your treatment options, and that you feel that you have a voice in asking the right questions so you get care that aligns with your goals and wishes. And the real world story that I had the ability to work with a patient where care navigation and patient advocacy were actually both part of her healthcare journey. So this was a young woman who had an abnormal echocardiogram, basically an ultrasound of her heart that showed she could potentially have a blocked artery. Her primary care provider referred her to a cardiologist. She saw the cardiologist who said, we can definitively rule this out by having you have a heart catheterization, which is an invasive procedure that looks directly at the heart. The care navigator for that cardiologist's office got the prior authorization, got the test approved by the insurance company, and that patient was scheduled. She reached out to me because she didn't really understand her test results. She was questioning them. She was a healthy woman who didn't have any other cardiovascular risks. She was scared to have an invasive procedure. She would have to take time off of work. Her husband would have to take her for this procedure. So she reached out to me. And in our conversations, I was able to relay to her that for someone of her stature, her age and gender, this echocardiogram had a 53% false positive rate. So meaning over half of the time, it returns a positive result when the person actually doesn't have a blockage in their artery. Knowing that, and then also letting her know that there are other tests like a coronary CT angiogram, which is a non-invasive test, an imaging study, is 98% effective in ruling out coronary artery disease. So with having that knowledge, she was able to return to the cardiologist, asked informed questions, and she was able to make an informed decision for herself, both medically and financially. She got appropriate care. She went with the coronary CT angiogram because the 2% difference was not worth the risk of having an invasive procedure. The heart catheterization would have resulted in a claim to her employer at around $6,000, and the CCTA is a $600 test. So, that's just one of many examples that when you as a patient are equipped with knowing your options and feel that you have a voice with that provider, you can open up a dialogue where you can align your wishes with good care.
Perfect. Thanks, Shannon. Dean, let's talk about the problems you solve.
Well, I think we're all accustomed to the way we all go access healthcare, right? We got this little plastic insurance card, and we treat it like an admission ticket to get into the doctor. And so you take your admission ticket, you hand it to the front desk, you get your service, and then the surprise happens, right? You get the bill. And that's when it's revealed what you just paid for that thing, either you individually or your health plan. And if you got a surgical service, you're going to get about 4 bills from each from the facility, from the performing surgeon, from the anesthesiology group, from the lab. None of the bills will make any sense. They'll have very high dollars. And then the EOBs will start showing up because, oh, it got run through insurance, and they start showing you what supposed discounts they got. And it's all confusing, and all of your employees deal with that every single day. They got to deal with not knowing the price of anything and then being surprised after the fact. We're trying to eliminate all of that. We show the price up front. And again, most of our clients implement with a zero out-of-pocket structure for the member. So now the member has an incentive not to use that little plastic card. They can if they want to, and if they do, they will pay their deductible, their co-insurance, their co-payments, their max out-of-pockets. But if they go down the path of transparency, and if you encourage them to do that with zero out-of-pocket, they're going to make that choice, and then everything gets cheaper because, as Shane said, when prices are disclosed, they come down. And the best part about it is if you're moving people out of large hospital systems where they charge 300+% of Medicare, you'll typically get direct pricing closer to 125 to 150% of Medicare. And that's why employers are happy to pay the full cost to remove all the patient out of pocket, because prices, when they are transparent, fall.
Yeah. Remind me again, Dean, what are the types of services that we're talking about? A lot of us, sometimes we go to the place of like, well, I mean, you know, heart surgery or, you know, some emergency care. No, there's a specific kind of niche that you're working with.
Right. So we cover basically the fat middle, as I call it. So emergency services. If you're in an ambulance on your way to the ER, you're not shopping for health care. So we're not talking about emergency services. We are also not talking about direct primary care and other advocacy. That's a separate thing. We handle all the things in between. So that can be imaging, PT, any surgical procedure. We have maternity services. I mean, anything that is a scheduled service, which is 95% of healthcare, you can shop for and buy transparently.
Nice. One more for you, Dean. This kind of concept floats around in my head a little bit at times. And, you know, we've got employees, even some of us in the room, we're coupon clippers, whatever we want to call us, where we're hunting for deals, okay? I believe, you know, if maybe some of the previous objections to like saying, oh, well, you know, our employees, they don't really do that, or they don't shop for it. I believe that the coupon clippers and the deal shoppers, they're already at your company. They're there, and we want to let them loose. We can't let them loose. They're out there. Dean, why don't you, you know, talk a little bit about that? And I'm going to tie in this comment of this perception of like rich benefits, where like everything is covered, versus active healthcare purchasing, which are the coupon clipper folks. Talk on that for a second, would you?
Yeah, so, and again, I keep going back to comments from Shane that I agreed with all of it. You know, narrow networks can be a concern, right? Because you're starting to restrict the number of providers that are available. I actually am an advocate for narrow networks when they are paired with a broad insurance-based network or RBP network, right? So now you've got kind of the best of both worlds. It's like, again, you, plan participant, can go to whoever you want, but if you go down that non-transparent insurance-based path, the patient, are going to pay out of pocket for making that choice, for going down that non-transparent path. But when you couple it with, as Shane said, a tier 0 option, where you encourage them to go down the transparent path, where both they can win with zero out of pocket, and you, the employer, can win by just paying fundamentally less. And don't forget, you win twice on this. You pay less for the service in the current claim year, and because that you paid less, your renewal actually gets lower for the next year. So it's a double, and it compounds. So it's a strategy that pays off for multiple years.
But it's got to be easy.
It's got the two things I always say: if we're going to change people's behavior, you got to give them a financial reason to do something different, which is why I'm advocating for zero out of pocket. And you got to make it easy. If you fail on either one of those points, people are not going to not do what we're talking about here. And they'll keep doing it the way they always have, which is overpaying for non-transparent services.
Yeah. Thank you. Let's shift a little bit. I think Shane touched a bit on just some of the barriers we're up against and misaligned incentives. Paul, I'll start with you. Before I do, though, I'll go first. If you're not familiar with it, there's some, the commentary, the structure is around misaligned incentives in each one of the sectors of like the healthcare system. One being traditional healthcare or health insurance brokers. What is the incentive for us to lower a client's cost, other than just trying to keep a client happy and do a good job? There really is not an incentive for us to drive that down. Maybe even more bluntly put, what happens when you get a 20% increase? We technically get a 20% raise for a fully insured group. So, on the medical side, Paul, can you give an example of how misaligned incentives play out in your lane?
Yeah, currently, if your employees are using an insurance card to see their doctor, the misaligned incentive with that doctor is multiple-fold. First, they're incentivized on volume, not value. So when they see you in 10 minutes, they make the same as if they see you in 20 or 30 minutes. So the highest compensated doctors see 40 patients a day. So it's a patient every 8 minutes or so. The lowest compensated doctors see 20 patients a day, or 10 patients in a half day, or a patient every 20 minutes. Most doctors see about 24 patients a day on average, or a patient every 15-ish, 18-ish minutes. The double whammy comes in is if that doctor is employed by a hospital system. That hospital system will insist, do not do the joint injection, do not do the skin biopsy, do not do the earwax removal. Refer that to orthopedics, dermatology, and ENT in the system, in our hospital system, because we get to bill for an outpatient visit, a procedure visit, and a pathology fee. And so instead of the cost of let's do a simple one, skin biopsy. If we perform a skin biopsy at our office, there's no charge for it other than a $75 pathology fee. If I was in the hospital system and referred to a dermatologist in system, you'd have a $350 visit fee, a $350 procedure fee, and a $350 pathology fee, or about that. So you're paying about $1,000 on a service that should cost about $100 or $75. So those are the misaligned incentives. And you'll also have the doctors, the primary care physician employed by the hospital or taking insurance, refer to the hospital imaging department, and I'll pick on Beaumont here, the two-way street here. But Beaumont will charge $3,800 for a brain MRI. If you went to Basha Diagnostics or Regional Medical Imaging down the street here on Woodward Avenue, that cost would be $380.
Can I jump in just for 1 second?
Sure.
For, if you have one of your employees that's going to go out and they're going to take a client out for dinner, are they going to get slapped on the wrist if they spend $3,000 on dinner versus a $300 dinner? When we put it that way, again, I know these are healthcare things, we're getting in people's business, but still, it's a reality. It's like, if you found out one of your employees was spending $3,000 on dinner, it would be worth a conversation.
Yeah, so those are the misaligned incentives, and the solution that we propose as a direct primary care group is that when you see us, we have an hour with you. Therefore, we have the time to do the knee joint injection, the earwax removal for free, the skin biopsy at a $75 pathology fee, which is an outside fee. And your employee has the benefit of reduced absenteeism, reduce presenteeism, right? They're in the office more because they just need an hour with us or 30 minutes with us rather than multiple visit with multiple specialists and the 3 to 6 to 8 month wait time that it takes to get in to see one of those specialists.
Yeah. To round it out, I'm being redundant at this point, but what sticks out to me is the independent practice is dying. Per Shane's words, per your words, and a lot of the primary care offices, right? We're driving around, we see all the big hospital logos on them. Again,
That's
no
right.
vicious intent. There's good people in there, but it's just a business model.
Yeah, great doctors in a bad system, as I would say.
Nice. Great quote. Okay. Thank you. Shannon.
Yeah, I think from my perspective, the growth of insurance has cleaved the relationship between the patient and the provider. So now, as a provider, if you are in an independent practice, and this is why a lot of providers are employed by hospital systems, because you have a fixed income. You know what your income is going to be a lot of times when you're employed by a hospital-type system. I was in a private practice for a long time, and me as a provider, I didn't know what I was going to get paid for any of your visits. I could get paid one amount to see one person and a totally different amount to see somebody else. And it was based on sometimes measures that were completely out of my control. And so as the provider, there's a distrust in the system and they don't know how to get paid and reimbursed appropriately. And you as the patient have no idea what you're getting charged. So when I stepped in the role of a patient advocate, I really see my job as to restore that patient-provider communication, because it's that communication that leads you to be able to make informed decisions for yourself, both medically and financially. And when you make those decisions, the downfold effect is that your employer is going to see, you as the employer are going to see cost savings because your employees are making better decisions for them.
Thanks. Dean.
I guess the thing I'd say about incentives is how many of them, how many layers there are of negative incentives. Again, Shane mentioned hospital CEOs are not showing up every day trying to figure out how to get paid less. They're wanting to get paid more. That's how businesses operate. The insurance company, as he also said, gets paid a percentage of the premiums that they collect, which are a downstream effect of the claim costs that they incur. Many brokerages get paid percentages from those insurance companies. And as Paul said, doctors who work for hospitals get what are called RVUs, relative value units. They literally get paid bonuses for how much referrals they make into the hospital system, whereas Paul said, everything's overpriced. So the whole thing is stacked against you, the whole thing. And so if you don't recognize those incentives and put in plans and strategies and benefit designs to counteract them, you're going to get the 5, 10, 15, 20+% renewals year after year. I mean, we've got 20+ years of this and 20 more coming if we don't make some changes.
Thank you. Let's shift into a little hope now. Little hope. Shannon, why don't you start, give us a little bit of information about FMMA, what that is. It's probably going to be a new acronym. Tell us about what that is and your involvement.
Yeah, so both Dan and I are part of the Free Market Medical Association. I'm the chapter lead for Michigan. And I will tell you, once I got involved with the Free Market Medical Association and I saw what was happening across the country, it was amazing to me how far behind Michigan is as a state. There are several states. Oklahoma City is where the founder of the Free Market Medical Association is from. He is an anesthesiologist who was, doing anesthesia and surgery and saw how awful the payer system was and that patients didn't know what they were being charged. Everyone was getting charged different, and he just consciously couldn't be a part of it. So he actually rented out a hospital, one of the suites, surgical suites in the hospital, and that's how it started. And now he owns the Oklahoma City Surgical Center, where people from all over the country, and quite frankly the world, he has a lot of people from Canada, because he has, like Dean has posted on his website, prices that are transparent, that are all-inclusive. So the cost for the total knee is the cost for the total knee. There are no surprises. That is what you are going to pay. and it's far less than what you would traditionally pay with your insurance. So the principles really are that everyone pays the same price. A total knee costs the same price for me as it does for Paul, as it does for Dean. That it's transparent, you know what it is going to cost, and that it's bundled as one price. And so my role here in Michigan is really, you as employer groups, if you don't have providers and surgical centers who are opting for a cash-based model, you are kind of stuck. You don't have solutions. So my goal is to try to educate our providers here and surgical centers and get them on websites like Dean's so you can shop around for, best prices.
Thank you. Dean, FMMA, comments, thoughts?
I don't know that I have a lot to add to that.
good.
I think Shannon summarized it well. It's easy to become a member, and Shannon can tell you how to do that here in Michigan. And I really would advocate for it. I think it would be a good use of your time. There's a lot of free thinkers in the Free Market Medical Association, and they're people you should know.
Yeah. Thank you. Okay, on the continued front of hope, listen, we understand the barriers to change, either size or just, the workload, the unknown, all that. But let's talk about, as a group here, the attributes that some of these employers that have said, I've had enough. I'm ready to do something a little different. I'm not reckless because, maybe with some of those employers, they're just out there. The way they do things is just, I wouldn't do that. I'm sure there's some more conservative folks that have said, I've had enough. I'm going to do it different. Let's just talk about the attributes that they carry. Paul, fire away. You've seen some in Michigan.
Yeah, we work with many groups, many self-funded groups, level-funded groups who are looking to save money. We are blessed to be sitting in the Townsend Hotel, who we're working with as well, to help them lower their costs of care. We work with school districts across the state. They're actively looking for changes in how their employees get health care. They care deeply about their employees. They want them to get excellent care. They found that the current system is broken and not serving their employees well. And they have institutional buy-in where they have a lot of people in the organization who want to drive that change forward, who remind them, use the clinic, see the DPC doctor, the direct primary care doctor, go over to Plum Health. And then they are willing to host us for on-site things like flu shots and blood pressure checks and blood sugar checks to encourage that engagement. We work with several groups across the state of Michigan. We have 5 offices: Detroit, Royal Oak, Lansing, Corona, Van Buren, and we serve a good number of patients across the state. It's been a lot of fun to help these groups save money, get the care, and have that immediacy that they need.
So again, the attributes, there's a willingness that these employers just say, I think it's time for change. Also, I know specifically of folks that we've worked with or had thoughtful conversations, is there's a point where their deductible gets to a certain point, and then they start to think that, well, if our employees don't even have, on average, $1,000 in their savings account or checking account, they're functionally uninsured, right? They've got bills that are just there. So there's a pressure to change something to be different that I think a lot of those folks are probably navigating.
Yeah, if I may piggyback on that. Yeah. 20 to 30% of Americans don't have a primary care doctor. And then about half of Americans don't have enough money to cover a $500 or $1,000 expense. And so you have a lot of employees in your organizations who are sitting there with a medical problem that they know that they have, who are not seeking care because they're worried about what it's going to cost for the copay, how is it going to hit my deductible, what's that balance bill going to look like for the non-covered services. Like if your employee might see a covered dermatologist, but then the dermatologist sends a pathology sample to a pathologist that's outside of their network, unbeknownst to them, and they get a balance bill of $350. They've had that experience in the past, and they're already thinking twice about accessing care. So what the groups that we work with know is they want a partner that can give them $0 access to excellent primary care.
Thanks. Shannon, attributes that these employers hold?
Yeah, I think as employer groups, it can be overwhelming to look at the big picture. Know that even your small steps can have ripple effects and change your dynamics of your company. I, work with several fully funded people, and just kind of seeing how I can help navigate what they currently have has opened their eyes to maybe the possibility of doing it differently. Sometimes you need to see how you can fix what you already have and make it work best for you, to understand that taking that leap to maybe a level funded or self-funded is not out of the question. Because, for one of the fully funded groups, I looked through their plan, and their prescription coverage was $10 across the board for any generic med for a 30-day supply. Well, don't use your insurance, because you can go on Cost Plus Drugs and get a mail order for a 90-day supply for $5.50. So it's not even worth you to use your insurance. And especially when you have the majority of people now only being able to afford high deductible plans, you are a cash paying patient. So you need to look for, I am a total coupon clipper. I had a high load driver for a dad and a stay at home mom. So that's ingrained in me to get the best value for the lowest price. And you have to understand your plan well to be able to use it to its benefit, and then know where you need to not use your plan because it's going to cost you more money.
So baby steps.
Yeah.
Right?
Yeah.
Yeah.
I think baby steps can lead to great change.
Dean?
I'd say probably 4 attributes I see for companies that are kind of winning the war against healthcare costs. Number 1, they have a belief that they can do something, right? Because if you don't believe there's anything in your power to change, then you won't change. So number 1, you got to believe you can make a change. Number 2, I think plans that are succeeding are data-driven, meaning just find the data, go get the data and use it, analyze it, make decisions from it. The next thing is they pay a lot of attention to the incentives that we've already talked about. They're fully aware of the tide that is pushing against them from a negative incentive standpoint. And then the 4th thing I'd say, which kind of wraps all the other 3 together, is they embrace their fiduciary responsibility. Because if you run a health plan, you are a fiduciary of that health plan, which means you have to put the member's interest ahead of the company's interest, actually, which is a tough tightrope to walk for sure. And so, again, if you're running a health plan, you're a fiduciary, and I think embracing that fiduciary responsibility actually ends up driving a lot of positive downstream change.
Perfect. Thank you. I think we would be open if there's any questions that are bubbling out there. We'd love to answer them. I'm not trying to put you in the hot seat, everyone. Maybe none. Okay. Oh.
Yeah. I mean, how do our clients engage with Dean, Dr. Paul, and Shannon? What's the methodology there?
Yeah. I mean, we can, for each group, it's going to be a little more specific. It's if it's a fit for them, but, Paul and Shannon's are a little more ready to go in the state. Dean, I know you have a presence here. I'll let each one of them answer briefly just because I know we're wrapping up, but
Sure.
give us the 30-second punchy
The question
answer.
is, how do your groups engage with us? So I have our Chief Operating Officer, Tommy DeGuano, in the back in yellow glasses, and also our new nurse navigator, Joey Brender, who's helping us as well with getting our patients to the right spot. But in brief, we like to see your trailing 12 months claims, and we use that data to run a report and show you if you invest in your primary care spend, here's where we can save you money on medications, labs, imaging services, all, let's just say 70% or 50% reduction. We use some conservative estimates up to 90%. Then we show you where we can save on specialist care, ER visits, and urgent care visits. And we give that report back to you in a couple weeks, and we show you where you can save the money. And then if you are we also do a geo study and show you where your employees could plug into our clinics. And if you were large enough, we would go out and build a clinic for you. So usually with 1,000 lives in that clinic.
Shannon, how can they work with you?
Yeah, my model is pretty simple. We partner with you, and it's based on a retainer model because we know not all of your employees are going to be faced with a medical decision in a calendar year. So the retainer model spreads your burden across all your employees, and then you determine on your client size and your employee size how many hours. We have some rough averages to use as a kind of a benchmark of anticipated hours of services your employees may need. And then your employees access us directly through a referral code on our website. So you are hands off in their care, because one of the barriers for employees is not wanting their HR to really know what their health issues are. And so we try to remove that barrier, and then they know they have a trusted person. We come on site. I'm a big believer that people are not going to be open to going to independent imaging centers or these other places if they don't have trust in the person who are recommending these. So we come to your employment center, I meet your people. I typically will give like a quick sheet of just how to use your benefits that you have now to your best advantage for your employees. And we just try to keep it simple and not complicate the system anymore.
Dean?
Similar to Paul, we do a historical claims analysis, usually a year or two, and we literally go through and reprice everything. We say, well, here's what you paid for this joint replacement, $50,000. Here, you could have bought it at an independent ambulatory surgery center for half that cost, $25,000. We add all of that up, and we show you actually what you could have saved. We also do a census analysis. We will look where your members are. We actually build in markets when we have an employer raising their hand saying, I want this for my employees. Then we parachute into that market and we start recruiting doctors, mostly independent doctors, who are willing to offer fair and transparent prices. And we check them on that. We make sure their prices really are fair and transparent.
So Dean's waiting on you, kind of, and the provider group. Anyway, guys, this was great. I love talking with you. Like I just feel like Dean, I think you might have said, fighting the good fight in healthcare or winning the war on healthcare. It can certainly be that way. That is a blunt term, but I mean, is what it is. But you guys are doing great work. Thanks for being involved. Yeah, session 2 is a wrap.
Thank you, Luke.